So nutritional diseases, they are usually most commonly seen in developing countries where there's improper food intake or junk food, mostly because of the processed food presently being carried on by individuals and their sedentary lifestyles. So there are certain nutritional disorders or nutritional diseases which have been accompanied along with the developing countries. And amongst them, it's more important to know each and every definition, what the nutrition consists of, and what are the important properties of the nutrition for the nutrition to be maintained in the human body. Amongst them, let's deal with a few of the definitions, basic definitions, and basic ingredients which are required to maintain the nutrients in our body. Amongst them, energy is one which is required for the daily activity, and this is usually calculated in form of kilocalories per day, and usually average requirement, it is usually calculated by a formula differently. It varies among the sex, that is amongst the males it is carried out with a formula of 900 plus 100 weight for males, whereas in females it is 700 plus 7 weight for females, where W consists of weight of individual in kgs. So the energy, it could be consumed in the form of food or otherwise in the form of internal metabolic and physiological functions. Next, coming to proteins, usually the proteins are considered to be the building blocks of our human body, and these proteins are usually made up of amino acids and the internal and in the internal systems which usually build up this proteins starts from the nucleus and its constituents. So proteins constitute the metabolic fuel of energy, and usually it is 1 gram of protein which provides 4 kilocalories when calculated in terms of energy. So the average requirement for a human individual, it is 0.6 grams per kg, and it is calculated as 10 to 14% of calorie requirement per day in a human being. Coming to fats, which constitute 35% of all the diet in the human body, and these fats can be calculated. They are further divided or classified into minor products such as polyunsaturated fats, saturated fats, and trans fats, as well as monounsaturated fats. So these polyunsaturated fats, they usually comprise of less than 10% of all the calories being intaken. And coming to saturated fats and the trans fats, they constitute less than 10% of the calories, whereas monounsaturated fats, they constitute the remaining percentage of the total fat which is being intaken. So 1 gram of fat, it yields 9 kilocalories of energy per day. Next, coming is carbohydrates, which are the major source of dietary calories, and usually they are taken as 1 gram which provides 4 calories into a human. There are few even minerals which have even been constituted, and lack of these minerals or deficiency in these minerals helps in improper or alterations in the body maintaining system or the body functioning system. And amongst them, the major important minerals are the iron, calcium, and phosphorus. And whereas the minerals which are required in trace quantities, that is in minor quantities, they are the zinc, iodine, chlorine, sodium, potassium, magnesium, manganese, and so on. So any deficiency in these minerals can result in lesion formations or otherwise syndromes. That is, it could show a group of symptoms in the individual who is suffering from improper or insufficient mineral intake. Next, coming is water. Since water is being lost from the human body by excretion and exhalation, and because in certain conditions like any alterations in the hydration, that is, it could be overhydration or underhydration, so water is important to be maintained in our body. So the amount of water which is being lost is supposed to be compensated with the amount of water which is to be intaken. So the average requirement for a human individual is 1 to 1.5 ml of water per kilocalories of energy spent. Coming to the non-essential nutrients, they are the dietary fibers. They usually help in maintaining the body physiological functioning systems and in the digestion as well. And they are constitute the fibers which are taken in the form of fruits and vegetables. And they usually have a property and they in functioning such that they reduce the risk of colon cancer, coronary artery disease, as well as in diabetes. So these are certain functions of the non-essential nutrients. Coming to vitamins, which are usually the exogenous source of intake of food, and usually they are not produced in body by the normal body functioning system, that is, they are not synthesized in the body, whereas they have to be taken as an exogenous source, that is in the form of diet. So they help in maintaining the normal structure as well as functions of the cells, and these vitamins are broadly classified into fat soluble vitamins and water soluble vitamins. So any individual deficiency syndromes or otherwise multiple deficiency state is usually because of these vitamins, and among them the water soluble vitamins, they are the vitamin A, D, E and K, whereas the fat soluble vitamins, they are the vitamin C and vitamin B and the complex of the vitamin. Other than that, there are even certain vitamins which have been recently introduced, they are the choline, biotin and flavonoids. Coming to the pathogenesis of the deficiency disease, that is any deficiency amongst the previously described, that is the energy or the carbohydrates or the nutrients or the mineral content or water, might lead to certain deficiency disease, and these deficiency diseases are majorly because of primary deficiency or otherwise secondary deficiency. Primary deficiency, it means that the majorly there is lack of a particular substance in the diet, and this is because and it could be defined as a primary deficiency, which is because of either lack or decreased amount of essential nutrients in the diet. That is the cause of the disease can be known. Whereas in secondary or condition deficiency, we see that it's not because of the lack of the essential nutrients in the diet, but rather it is because of certain conditions which which cause disturbances in these nutritions in the nutrient intake or absorption or transport or excretion. So it is majorly because of malnutrition, and this malnutrition usually occurs in case of interference with ingestion, such as patients who are allergic to certain nutrients cannot take those nutrients, and because of that it might lead to a secondary deficiency. Whereas interference with absorption, usually the nutrients are being absorbed in the intestine, liver, so any dysfunction in the gut or otherwise any malabsorption syndrome, that might lead to interference in the absorption, thereby providing less number of nutrients to the body. And next coming is interference with utilization, since these are further utilized by the body systems, so any nutrient disorders, it could be because of improper functioning of the liver or otherwise the other kidney systems, which actually convert these nutrients into metabolic byproducts and make them useful for the human body. So any interference or alterations in these systems can result in interference utilization, thereby providing reduced nutrients in the body and resulting in secondary or condition deficiency, leading to deficiency disease. And next coming is increased excretion, that is if there is any, in case of polyuria or otherwise perspiration, there is increased loss of these nutrients in the form of sweat or otherwise in the form of urine. So there are insufficient nutrients for the body, which might also result in deficiency disease. And suppose of increased nutritional demand, usually there's increased nutritional demand in cases of certain conditions like hormonal imbalances in females, like in menopause or either in lactating mother or feeding mother, and even in a pregnancy condition. So there's increased requirement of these nutrients in the diet, but they are not improperly taken, which might also result in deficiency disease. So these are certain causes why the deficiency disease occur. Next coming is obesity. Obesity, it is usually defined as an excess of the adipose tissue that imparts health risk. So this results when a calorie intake is too much, that is excessive intake of the calorie or overloading of the calorie within the body results in accumulation of the fat. That is, this fat is usually present in the adipose cells, which are, so it is called as and the adipose tissue is present within this adipose cells, and so it is known as adipocytes. These cells are known as adipocytes. So usually we find that it is a kind of health risk because it might even develop, it might lead into certain heart disease also. So a body weight of more than 20% excess over the ideal weight for age, sex and height, it is considered to be, a patient is considered to be obese, and it is kind of health risk for developing any heart disease or atherosclerosis or even further other disease like diabetes. These all contribute to the obesity. Coming to it is usually measured, obesity is calculated as by a body mass index, that is BMI, and it is widely used to gauge the obesity. So it is calculated equal to weight in kgs, kilograms per height in meter square. So usually the cutoff value of the BMI is 30 for obesity. Coming to the etiology, usually we see obesity, since it is because of the overload of the calories within our body, and these calories are being excessively intaken, and this calories could be in the form of junk food or otherwise processed food, and over intake of this junk food and processed food as in the present lifestyle can be one of the cause for obesity to develop. Other than that, if the patient is the obese individual is usually inactive or otherwise is exposed to a sedentary lifestyle, then it might also be one of the reason for being obese. And since there's a patient then since the individual is inactive, there's no sufficient physical activity for the body for the amount of energy or calories being intaken, by which these calories get accumulated and make the patient or the individual obese. Usually, and it has been also observed that there's a genetic predisposition, that is it has been observed that it could also be familial or hereditary, and there have been certain identical twins who have been observed with this obesity condition. And there have also been certain genes which have been observed with this in the obesity conditions, and where they have observed genes which have been present in the parents as well as in the offsprings. Coming to the next etiological the cause for the obesity is diets largely derived from carbohydrates and fats. Already explained, since developing lifestyle or the sedentary lifestyle, it is also one of the reason for why there is too much of intake of these processed foods which have already been processed and which have been stored and which have been utilized at the time of intake of food, which might also lead to one of the cause of obesity. Next, coming to secondary obesity, because it is the primary cause is not because of obesity, rather because of the alteration in the endocrinal imbalances, which could be because of hyperthyroidism or any adrenal gland dysfunctions might also result in secondary obesity. Coming to the pathogenesis, how obesity occurs. Usually adipocytes, as already explained, they are the cells which constitute this adipose tissue, and these adipocytes usually cause the accumulation of this fat under the beneath the skin, which makes the patient appears fluffy in nature. And these, other than that, the adipocytes also have certain other functions, that is, they release certain endocrine regulating molecules. Among them, they are the energy regulatory hormone, which is known as leptin, and cytokines. They are the tumor necrosis factor alpha as well as interleukin 6. Next coming is the insulin sensitivity regulating agents. They are the adiponectin and resistin, and the prothrombotic factors. They are the plasminogen activator inhibitor and the blood pressure regulating agent, that is the angiotensinogen. So these are certain factors which are being released by the endocrine regulator, which are being released by the adipocytes. So obesity is because of increase in the adipose mass, and this adipose mass is because of increase in the adipocytes, and these adipocytes are usually fat containing cells and fat in the form of adipose tissue, and so these cells are known as adipocytes or adipose cells, and they usually consist of increased intracellularly lipids present, and this intracellular lipid deposition might result in an increased number of adipose cells, and this adipose cells together constitute the adipose tissue, which is usually seen just beneath the skin. And so excessive consumption of nutrients is also one of the reason for obesity. Coming to the signs and symptoms among this obese patients, we see that usually patient is more prone to stroke because of the increased association of obese patients with atherosclerosis and hypertension. That is, thickening of the blood vessel wall is atherosclerosis, and hypertension. Hypertension is also seen in these obese patients because of the increase in the blood volume pressure, because these both contribute or lead to stroke in the patient. And the heart diseases, that is because of the abnormal lipid profile, that is, in these patients we usually see the cholesterol being transported or circulated in the plasma in the form of triglycerides, and these triglycerides are usually the low density lipids and low density lipoproteins and very low density lipoproteins, which are usually harmful to the body and which are supposed to be maintained in a normal range, but these are usually seen most commonly associated than the usually protecting triglycerides, the high density lipoproteins, which are usually protective to the to any human body from cholesterol. But we see that rather than the high density lipoproteins, there are more number of very low density lipoproteins as low density lipoproteins, which are usually seen as bad cholesterol in the body, which might lead to abnormal accumulation of the cholesterol and also the alteration of the blood pressure, leading to one of the heart disease. So this is the reason for heart disease, that is the abnormal lipid profile. Next is the high blood pressure. As already told, patients are usually hypertensive in obese conditions. And other than that, diabetes, usually we see to a type 2 diabetes is being seen in these obese patients, and hyperglycemia is a condition which is being seen associated, though is hyperinsulinemia is also there. And this hyperglycemia is mostly because of the state of resistance to the insulin receptors, which is a consequence of insensitivity to insulin. So these patients are more prone for diabetes. Coming to women, because of the abnormal periods, that is the improper endocrinal balances being maintained within the body, or otherwise because of infertility, patients might also become obese, and this is also one of the sign and symptom for the patient being obese. Sleep apnea, usually hypersomnolence during the day as well as during the night is seen in these conditions, and it is also because of the hypoventilation condition, which is known as Picquian disease. In this disease, we see that there is increase in the carbon dioxide retention within the body and hypoxia in these patients, which might result in hypoventilation and also cause sleep disorders such as sleep apnea. And coming to lung disease, and these patients, we see that they are more prone for asthma and pulmonary blood clots because of the improper maintenance of the blood pressure levels in the body, and because of increased breathing in these patients because of their overweight. And coming to the liver disease, usually fatty liver is seen, which might result in liver cirrhosis if the patient is being untreated. And this fatty liver is because of the improper metabolization of this cholesterol in these patients. And the other conditions which we see in the obese patients is arthritis. Because of the overweight of the patients, these patients are more prone for wear and tear of the joints, muscular joints, which might result in arthritis in these patients. Other than that, because with the presence of blood clots, patient might also experience thrombosis, and which results in improper treatment for this thrombosis might also result in inflamed veins. And gout is also one of the condition which can be seen, and rarely we see patients, these patients, cancer, it can also be a condition where the cancer could be because of a breast cancer, uterus cancer, colon cancer, esophageal cancer, pancreatic cancer, kidney cancer, prostate cancer. And these patients, most commonly, they are prone 6 times more than the normal individual for the gallstones, that is, or otherwise the stones within the kidney, gallbladder. Coming to next is starvation. Starvation, it is a condition where there is a state of overall deprivation of the nutrients, and this because of improper or inadequate nutrient intake, and this is most commonly seen in the individuals with low socioeconomic status and unhygiene conditions, and it is most commonly seen in areas countries such as Africa. And usually these patients, they manifest with the presence of lax, dry skin and muscle wasting, as well as internal organ atrophy. And this internal organ atrophy is because of the deliberate fasting, that is because of inadequate intake, because of the most commonly seen in low socioeconomic status of the patient, and in case of famine conditions, that is improper provision of the food for the patients. And otherwise it could also be because of the secondary undernutrition when there's in malabsorption conditions, such as when there's no improper diet, or otherwise in chronic conditions where the liver disease, this could result in internal organ atrophy. Coming to the changes, what we see in starvation, they are the metabolic changes, and they are broadly classified into the metabolic changes concerned with glucose, proteins and fats. In glucose, we usually see in conditions such as starvation, we see that the glucose stores usually which are present within the body, when the patient starves or is fasting for a day, it is enough for one day. These glucose stores can compensate the patient during the time period of fasting. So they are sufficient if the patient is fasting only for one day. So how this works out is these glucose stores, usually in insulin independent tissues, they utilize this glucose in the period of fasting, whereas the insulin dependent tissues, they stop taking up this glucose. So this compensates the glucose stores during the fasting condition. So once this glucose is being utilized by the tissue, insulin independent tissues, there's release of glycogen from the stores in the liver. That is, this glucogen which is being preserved in the liver, this starts being released to the tissues which require actually the presence of glucose, and by this there is normal maintenance of the blood glucose level, and this normal maintenance of the blood glucose level is followed by hepatic neogenesis, that is utilization of the liver glucose glycogen from the liver, and this followed by protein stores. Suppose a patient has not sufficient energy for up to 3 months, then these protein stores triglycerides start working up in the body and start compensating the period of insufficient nutrient intake, where these proteins from the stores, they are being broken down as proteins are being made up of amino acids. These amino acids are being released and they act as a fuel for hepatic gluconeogenesis for the synthesis of glucose, and thereby there is maintenance of glucose needs for the by the brain, as since the brain also requires glucose. Hepatic gluconeogenesis compensates that of the loss or that of the inadequate intake of the glucose in the body, and thereby once this glucose is being utilized by the brain, then it results in nitrogen imbalance because of the excretion of nitrogen compounds in the form of urea. So this is what happens when the patient is being starved or fasting for 3 months or improperly taking diet for 3 months. Next comes as the metabolic changes in the fat. Suppose a patient is starving for more than a week, the fat which is usually present, or the fat stores, they start breaking down. They are being utilized. This occurs by the increase of the protein breakdown, and this increased protein breakdown results triglycerides. These triglycerides of the adipose tissue are being released by the protein breakdown, and once these are released, these also start breaking down. These triglycerides, they are also being dissociated. They are dissociated in the form of glycerol and fatty acids, and thereby these are being further glycerol and fatty acids which have been derived from these triglycerides, they are further metabolized into ketone bodies, and these ketone bodies are being utilized for the brain instead of glucose when the patient is starving for more than a week, and whereas the glucose stores have been utilized. And then if the patient still continues starvation in spite of after a week, then the patient might result in death. So these are the for certain metabolic changes when the patient is starving based on the duration of the fasting. Coming next to protein energy malnutrition. So usually since protein and energy which are being consumed in the form of diet, when there is any lack or inadequate intake, it might result in malnutrition. So it is properly defined as inadequate consumption of protein and energy as a result of primary dietary deficiency or otherwise secondary deficiency, which is also known as condition deficiency, which may cause loss of body mass and adipose tissue. This results in protein energy or protein calorie malnutrition, which is being abbreviated as PEM and PCM. So coming to the clinical syndromes which result because of the protein energy malnutrition, most commonly seen as kwashiorkor and marasmus. Kwashiorkor is because the calorie intake is sufficient, but whereas the nutrient intake the protein intake is not sufficient, it is inadequate, resulting in protein deficiency and sufficient calorie. Whereas marasmus, we see that the patient is starving in infants. It occurs due to overall lack of calories. So marasmus is a condition which we see most commonly in infants when the calorie intake is completely absent. So coming to the differences between kwashiorkor and marasmus, usually marasmus is a condition, as already explained in the definition, it occurs in infants, that is under the age of 1 year. Whereas kwashiorkor, it is seen from the age range of 6 months to 3 years. And kwashiorkor is usually characterized by muscle wasting, but there's as already explained, it is the sufficient calorie intake. So the adipose tissues which have been preserved are being utilized by this muscles. Whereas in marasmus, it is because of the starvation of the infant, there's complete wasting of all the tissues. Unlike in kwashiorkor, it is only muscle wasting, but in marasmus, we see that there's also wasting of all other tissue other than the muscle. It could be the adipose tissue as well. And usually in these patients we see the symptoms such as obesity can be seen kwashiorkor, whereas it could be a localized obesity concerned only to one organ, or otherwise it could be the generalized where it might involve the entire body. Whereas in marasmus we don't see such kind of obese condition, since it occurs in an infant, and this infant since edema is the intracellular accumulation of the fluid which has been escaped from the body circulating fluids, so since the fluid when compared to the elderly individuals, in infants it is low, so edema such kind of conditions is not seen in marasmus. So coming to the other features which we see commonly both in kwashiorkor and marasmus is that the serum proteins are low and patient is anemic, as well as there is growth failure, since these are the conditions which are seen in childhood. The child may not grow further. And other sign is most commonly characteristic sign of kwashiorkor is flat sign. That is, we see that there's presence of alternate bands of light and dark hair in these patients. That is, the patient might show presence of depigmentation as well as hyperpigmentation. Whereas in marasmus, a characteristic feature is monkey-like face, where we see protuberance of the abdomen. That is, abdomen is completely excessively, progressively being exposed, and the patient has thin limbs. So these are the important cardinal features or the characteristic features to differentiate a patient of kwashiorkor and marasmus. And other than that, we also see atrophy of different tissues and organs in case of progressive cases of kwashiorkor, whereas in marasmus also we see that there's atrophy of all the organs as already explained, and but in kwashiorkor there's preservation of this adipose tissue, whereas in marasmus adipose tissue wasting is also being seen, which might result in atrophy of this adipose tissue. And in kwashiorkor we see there's enlargement of the liver, that is, enlarged fatty liver is being observed because of improper nutrients present and excessive calorie intake, whereas in marasmus we do not see such fatty liver because of the calories or the nutrients which have been present are being further utilized by the human body, thereby there is complete inadequate, and these patients we see death very soon in marasmus. So there is a picture showing kwashiorkor and marasmus. Next, coming to the disorders of vitamins, since vitamins are the organic substances which cannot be synthesized in the body and they are essential for the maintenance of normal structure and function of the cells, they are properly to be taken by the exogenous source, that is in the form of diet, food. So it must be provided in the form of human diet. These vitamins, they are broadly classified into fat-soluble vitamins and water-soluble vitamins. Among the fat-soluble vitamins, it is the vitamin A, D, E and K, whereas the water-soluble vitamins, they are the vitamin C, vitamin B, along with the certain other members of this vitamin B. Then recently being added water-soluble vitamins, they are the choline, biotin and flavonoids. Coming to the etiology why the vitamin deficiency occurs, based on it also depends on the regional variances. In developing countries, usually it is seen that there is generalized malnutrition of the dietary origin, whereas in developed countries we see that the children, it is most commonly seen in case of children, adolescents, pregnancy period, in lactating women, as well as in some cases of poverty. That is in conditions like low socioeconomic status, where there is insufficient intake of the food because of their status. Next coming, vitamin deficiency could also be because of the secondary causes, that is, it is not directly because of the inadequate intake in the form of diet, but rather it is because diet is being appropriately provided, but whereas these vitamins are not being metabolized further in the body, that is, there could be interference in the ingestion, absorption, utilization or otherwise in excretion. Coming to vitamin A, which is also known as retinol, it is usually a fat-soluble alcohol and it is usually present in the diet either in the form of performed retinol or otherwise provitamin precursor carotenoid. So these are the two forms of vitamin A. Coming to the physiological functions of retinol, usually retinol, that is vitamin A, it helps in maintaining the vision usually, and this retinol usually helps in providing two pigments. By this oxidation of this retinol, it provides two pigments in the cornea as well as in the sclera. They are the rhodopsin and iodopsins. And these structures are usually present in the rods as well as the sclera. Coming to vitamin A, it's a fat-soluble alcohol. It is available in two forms. That is in the preformed retinol, that is retinol which has been already formed, or otherwise in the form of precursor carotenoid, which is a provitamin. That is this provitamin precursor carotenoid. It is being taken in the form of beta carotene, which is usually present in vegetables such as potatoes, pumpkins, and even in carrots. So this beta carotenoid is usually absorbed intact in the abdominal mucosa, or otherwise once it reaches the intestine, this beta carotene can be converted into chemically converted into retinaldehyde, and this retinaldehyde further reduced to retinol. So this retinol, once it is formed, it starts binding to the circulating protein which is present in the body, and then this is transported to other structures. Whereas preformed retinol, it is usually present that is retinol which is usually present in other sources of the food, such as egg yolks, fish, and liver, kidneys also. So these are the two forms of vitamin A, which is a fat-soluble alcohol. And coming to the major functions of retinol, that is vitamin A, it usually helps in maintenance of normal vision in reduced light. Because retinol, since it undergoes oxidation, it produces two pigments, that is rhodopsin and iodopsin. Rhodopsin is a pigment which is usually present in rhodopsin. It is a pigment usually present in the cones. Rhodopsin is a pigment usually present in the rod, and it is usually sensitive to light, and whereas iodopsin, it is sensitive to bright light, and it is usually present in the cones. And these pigments usually, once they start exposed to the radiant energy, they start being converted to the nerve impulses, and thereby vision is being produced. Whereas coming to the next function of retinol is the maintenance of the structure and functions of the specialized epithelium. And this since these epithelium consists of glycoproteins, and this is being maintained. Retinol combines with this glycoprotein, and thereby it helps in maintenance of the structure and function of the specialized epithelium, such as the respiratory epithelium, which consists of columnar epithelium, and this columnar epithelium is also present in other structures such as the glands as well as the mucosal surfaces. The next next function is maintenance of the normal cartilaginous as well as bone growth. Since vitamin A is also involved in osteoclastic functioning of the bone growth, that is in the maintenance of the normal balance between the bone disposition and resorption, we see that vitamin A is also involved in maintenance of this bone growth. And the next coming is since vitamin A is also has an anti-proliferative effect. It shows an antioxidant properties which helps in suppressing certain tumor growths. And the final function of vitamin A, that is, it helps in maintaining the increased immunity against infections in children. Coming to the lesions which have been associated with vitamin A deficiency, since it is being already mentioned that it helps in maintaining the vision by controlling the factors of the pigments which are being present in the cones and rods of the eyes. It helps any deficiency in vitamin A might result in night blindness, and it also causes xerophthalmia, that is dryness and scaliness of the sclera or conjunctiva. And there's lacrimal duct hyperkeratosis is also seen, where the lacrimal duct shows increase in the keratin production, and corneal ulcers is also one of the features. Next coming is the keratomalacia, that is there will be plugging and increased in the keratin production, resulting in keratin plugging as well as hyperkeratosis. Bitoid spots is another feature. Bitoid spots are the focal triangular opacities which are present in the eye, and these focal triangular opacities along with the hyperkeratosis might result in blindness of this patient. So vitamin A serves a major role in vision, so any deficiency might also result in certain conditions of the ocular lesions. Next coming is, since vitamin A also maintains the role in maintaining the epithelium, so there are certain cutaneous lesions associated with the deficiency of vitamin A. It is a xeroderma. Xeroderma usually manifests as a toad-like skin, where we see that the patient shows a dry and scaliness of the overlying skin, superficial surface of the skin. And the other lesions most commonly we see is squamous metaplasia, that is it is a kind of physiological adaptation for certain foreign antigens or any changes in the normal maintenance of the epithelium, where we see usually in the respiratory epithelium that there is change from the columnar epithelium to squamous metaplasia. Next coming is a long-standing metaplasia. When there's in vitamin A deficiency, we see long-standing metaplasia, that is change in a regular form, that is a basic form of an epithelium to an physiologically adapted kind of epithelium, where this long-standing metaplasia, that is this progressive change of this regular basic epithelium might result in anaplastic epithelium, that is there's complete no resemblance from the parent cells to that of the daughter cells. Other than that, we also see there's retarding of the bone growth. Since we already explained, there's osteoclastic resorption is being also maintained by vitamin A. So any deficiency in vitamin A might result in increased in the bone resorption and causes improper maintenance of the bone growth. Coming to next is immune dysfunction. Vitamin A has also a role in immunoglobulins. So any deficiency in vitamin A might result in immune dysfunction. So these are the pictures showing xeroderma, that is the scaliness and the dryness of the skin, giving a toad-like appearance. Next coming is the white spots. They are the opacities which are being seen in the eye. Next is a papilloedema, which is seen as which might also manifest as a retinal hemorrhage in progressive cases. Coming to the next case, that is hypervitaminosis. When vitamin A is taken in excessive quantities, it is known as hypervitaminosis, and so it is defined as very large doses of vitamin A can produce toxic manifestations. They can be seen. These hypervitaminosis cases can also manifest in children as well as in adulthood. They are being broadly classified into acute toxicity and chronic toxicity. Acute toxicity, that is which shows rapid changes in the form of headache, vomiting, stupor and papilloedema. Stupor is a mentally retarded condition where the patient is not in conscience. Next comes the chronic toxicity, where we see long-term toxic conditions, that is over intake of vitamin A. It might result in neurological manifestations such as headache and disordered visions, whereas in skeletal pains, because of the its osteoclastic activity, increase in the osteoclastic, that is bone resorption conditions, and pruritus, and the cutaneous conditions, we see cutaneous lesions involved is pruritus, that is severe itching in the patient. Other than that, fissuring, that is radiating fissures. It could also involve the angles of the mouth. And next coming is the sores and coarseness of the hairs, where we see light as well as dark hairs, that is hyperpigmentation and depigmentation of the hair. And next feature associated with the chronic toxic condition in hypervitaminosis is hepatomegaly, where we see fatty liver, and hyperkeratinemia. Increase in the beta carotene results in hyperkeratinemia. Vitamin D, it is also known as calcitriol. It is usually available in two forms, that is in an activated form and an inactivated form. And the activated forms are considered to be vitamin D2 and vitamin D3. So vitamin D2 is also known as calciferol, whereas vitamin D3 is also known as cholecalciferol. And vitamin D1, it is an impure mixture of steroids. So these two forms, so vitamin D2 and D3, since they have a same characteristic biological as well as biochemical effect, they are known as vitamin D complex. And usually this vitamin D is acquired from an exogenous source as well as endogenous source. Endogenous source is one when a patient is exposed to sunlight, where the 80% of the UV light it starts showing its effect on the body, and it manifests as 7-dehydrocholesterol. Whereas the exogenous source, that is in the vitamin D taken in the form of diet, it could be in the form of deep sea fish oil, eggs, butter, milk, or otherwise in the form of grains or some kind of plants. So this is the physiology of vitamin D. So when a patient is being exposed to sunlight, then the patient absorbs this vitamin D. Otherwise, that is the endogenous, starts showing its endogenous effect. Whereas the exogenous source of vitamin D, that is in the form of food, as already explained, once it enters, it is being ingested by the individual. It is being absorbed by the intestine, and later it is being carried to the liver, where it further turns into an active form, and then it starts circulating within the bloodstream. So vitamin D, it is manufactured in the skin when the radiations are being absorbed, and after the it is being manufactured in the skin, that is after the absorption in the sunlight, then it starts moving to the liver. From the skin it moves to the liver. Once it reaches the liver, in the liver this vitamin D, it is converted into 25 dihydroxy calcidiol. That is, it is also known as calcidiol. It is a 25 dihydroxy calcidiol. It is a primary form, or otherwise known as an inactive form of circulating vitamin D. This is soon it reaches the kidney, and there in the kidney it is being converted into an active form which is known as 125 dihydroxycalciferol, also known as calcitriol. It is a biologically active form of vitamin D. So once once it is being converted in the kidney, it starts reaching the bloodstream, and thereby it shows its effects, such as it helps in mineralization of the bone. So the synthesis of vitamin D, it facilitates the absorption of calcium from the small intestine, and also whereas the calcium reabsorption from the kidneys and rebuilding of the bone tissues, that is by the formation of mineralization of the osteoid matrix. So this is the function of vitamin D in the body. So once after vitamin D is being metabolized in the liver and the kidney, after being absorbed from the radiation or otherwise being ingested through the food, it is converted into active metabolites. As already explained, they are the 25 dihydroxy vitamin D or calcidiol and 125 dihydroxy vitamin D or calcitriol. So this production by kidney is being regulated by certain other factors, and these factors are plasma levels of the calcitriol. That is calcitriol which is already existing in the blood levels, that is bound to the plasma. This is one of the reason for maintenance of the vitamin D in the body. And the next coming is the plasma calcium levels and the plasma phosphorus levels. So most of the vitamin D, it is being stored in the adipose tissue. Coming to the functions of calcitriol, so mainly vitamin D helps in maintenance of the blood plasma calcium as well as the phosphorus levels. In the form, how vitamin D helps is, vitamin D helps in intestinal absorption of the calcium and phosphorus and helps in maintaining these minerals in the blood. Other than that, vitamin D, it also shows on its effect on bones, that is, it helps in mineralization of the bone, whereas when there's in conditions such as hypocalcemia, this vitamin D, what it does is it absorbs the calcium from the bone and it releases into the blood plasma, thereby trying to maintain or compensating the levels of calcium and phosphorus in the blood. Next is, it also helps in the kidneys. The vitamin D causes the reabsorption of calcium, as well as phosphorus, thereby maintaining its level by releasing them into the plasma and maintaining its level in the blood. And vitamin D, as it has in certain receptors and on the cells, such as in parathyroid gland cells as well as in other cells such as cancer cells and skin cells, vitamin D starts showing its anti-proliferative effect, and this anti-proliferative effect is such that it helps in suppression of the growth in cases when it is when this vitamin D is being recognized by the receptors of the vitamin D on the cancer cells, then they start showing its once they bind, that is a receptor, and the vitamin D starts binding, then it starts showing its suppressive effects on the cancer cells, thereby manifesting its anti-proliferative effect. Whereas in the parathyroid, once the vitamin D starts attaching to the vitamin D receptor on the parathyroid gland cells, then it suppresses the parathormone gene. So these are the functions of calcitriol. Coming to the lesions in vitamin D deficiency, usually we see that there is reduced endogenous synthesis, since vitamin D, once it is being absorbed from the sunlight or being released into the body through the exogenous source in the form of food, then it is supposed to be converted into its active form, where it is being converted in the liver as calcidiol and in the kidney as calcitriol. So there is reduced endogenous synthesis when the sunlight, when there is inadequate exposure to the sunlight or inadequate intake of vitamin D in the form of diet. Then otherwise also, Lesions in vitamin D deficiency could also be because of dietary intake, that is when the exogenous source is not inadequate, that might result in lesions. Then lipid malabsorption. So vitamin D has also a role in absorption of the lipid which is present in the circulating blood. So any deficiency in vitamin D can also result in lipid malabsorption. Next is vitamin D derangements of the vitamin D metabolism. That is, in these patients usually we see that the metabolism when the vitamin D is being insufficiently being absorbed in the body, then vitamin D shows derangement in the metabolism, which thereby shows its effect on the bone mineralization and even in certain other antiproliferative effect. Coming to the last lesions which we see is there's resistance of the end organ to respond to vitamin D. So what happens if there is deficiency in vitamin D? So it usually causes rickets in children, whereas osteomalacia in adults, and hypocalcemia in tetani, that is due to neuromuscular disorders. So these are the deficiencies and the lesions associated with vitamin D deficiency. Coming to rickets, which is the most important property of vitamin D deficiency, where we see that vitamin D dependent rickets, it is an autosomal dominant disorder of vitamin D when it is not being sufficiently intaken. And it is the primary defects what we see in these patients is the interference with the mineralization of the bone. Since the vitamin D is not sufficient, mineralization of the osteoid matrix is not being properly maintained. Next, coming the primary defect is the derangement of the endochondral and the intermembranous bone growth. Since vitamin D causes the ossification of the immature osteoid matrix, or otherwise known as mineralization of this osteoid matrix. There is derangement in the bone growth, either because which is the ossification, if it could be depends on the position, that is it could be by endochondrous or otherwise intramembranous ossification. Then otherwise the other effect of primary defect in rickets is disease response rapidly to 125 dihydroxy vitamin D. That is when the patients have been in these rickets patients, they can be treated with 125 dihydroxy vitamin D supplements. So there is a features of rickets. Next, coming to the skeletal changes and the biochemical changes in patients of rickets, we see craniotapes. They are the ossifications which are being seen in the skull, and these patients usually show a square-shaped skull that is in the form of box form. And this square-shaped skull, it is usually comes to normal, and this ossifications usually become normal by 12 months, within 12 months of the birth of the patient. Next comes as a Harrison sulcus, which can be seen, where we see there's indrawing of the soft ribs in these patients, which gives an appearance of an Harrison skull. Next coming is rachitic rosary, where we see that the patients, when during inspiration, there's more of indrawing of these soft ribs, which gives a rachitic rosary appearance. Next comes is Pigeon chest, that is when the patient is breathing, breathing and expiration, we see that there's over protuberance of the abdominal upper abdominal area, which gives a pigeon chest appearance. Bow legs is the next feature. It is most commonly because of weak legs of the lower limbs in children, which gives a bow leg appearance. The knock knees, it is because of the enlargement of the terminal ends of the bones, such as tibia, fibula, and humerus, where we see, which gives a knock knee appearance. Lumbar lordosis is involvement of, when there's involvement of the spine in progressive cases, it results in lumbar lordosis. Coming to the biochemical changes in rickets patients, we see there's lowered activity of vitamin D metabolite levels because of, since it's a vitamin D deficiency, we see the metabolites after the vitamin D physiological metabolism function, the metabolites are reduced. Then the other features is normal and normal, otherwise slightly low plasma calcium levels in these patients can be observed. Since the vitamin D has a role in maintenance of the blood plasma and calcium levels, we see these levels are usually low. And other than that, even phosphorus levels are also low, and the alkaline phosphatase levels are also alkaline phosphatase levels usually they are raised because of the alterations in the mineralization of the osteoid matrix. So these are the certain biochemical changes and skeletal changes in the patient suffering from rickets. So these are the certain radiographic pictures showing rosary beads and pictures showing widening of the wrist because of the which gives an appearance in these patients as rheumatic conditions. And then next coming is patient showing bowed legs because of the last corner picture which shows bowed legs. It is because of the enlargement of the fibula and tibula. Coming to the ossification, how it differs from the normal bone growth to in the rickets, we see that the since it is majorly because of the alterations in the endochondral as well as in the intramembranous ossification. Endochondral ossification usually we see in cases of long tubular bones. Normally we see that the endochondral ossification is by mineralization to form, it means mineralization to form bone, whereas in rickets we see that there's deformed bones due to lack of structural rigidity. And in normal bone growth we see there's normal vascularization, whereas in rickets we see there's irregular overgrowth of the small blood vessels which is disorganized and results in weak bones. And coming to the intramembranous ossification, usually in normal bone growth, the mesenchymal cells, they differentiate into osteoblasts which develop osteoid matrix and then subsequently which mineralize. Whereas in rickets, we see that the mesenchymal cells, they differentiate into osteoblasts with laying down of the osteoid matrix and which fails to get the mineralization, resulting in soft and weak flat bones. These are the differences in the ossification when compared to that of the normal bone and rickets. Coming to osteomalacia, that is, it is a bone disorder seen in vitamin D deficiency disease seen in case of adults. Adult counterpart, or otherwise it is also known as adult counterpart of rickets. It is a failure of the mineralization of the osteoid matrix. That is, the osteoid matrix is properly deposited, but there's failure in its mineralization process. It usually occurs following the dietary deficiencies or otherwise poor endogenous synthesis of vitamin D and condition deficiency. Coming to the morphological features, what we observe in this vitamin D deficiency osteomalacia is that there's deficiency of vitamin D and osteoid matrix laid down. It fails to get mineralized as already explained. And microscopically, when we see the bone in osteomalacia, we see that it is widened and thickened osteoid seams are being seen. And other than that, there's also decreased mineralization at the borders, which is seen between the osteoid and the bone. And this is followed by increased osteoclastic activity as well as fibrosis of the marrow can also be seen. Coming to the clinical features, what manifests is in the patient is there's presence of muscular weakness, vague bony pains, fractures which occurs in cases of trivial trauma, and there's incomplete or green stick fractures, and there's also presence of looser zone which are otherwise called as pseudo fractures which are present at weak places in the bone. These are certain clinical features which are seen in osteomalacia. Next, coming to the biochemical changes, we see that the patient of osteomalacia usually shows normal or otherwise low serum calcium levels, whereas the plasma phosphorus levels are definitely lower, and there's whereas the serum alkaline phosphatase levels, they are increased. It is because of the increased osteoblastic activity. It is the similar features what we see in rickets. Coming to the differences in the normal bone and the osteomalacia bone, which we see that there is weak or incomplete ossification and mineralization, which results in porous kind of bony nature. Next coming is a hypervitaminosis. That is when there's over intake of the vitamin D, which might result in hypervitaminosis D. It might also cause alteration in the intestinal absorption of calcium and phosphorus, since vitamin D is responsible for maintaining the blood plasma calcium as well as the phosphorus level. So any reduction in any excess of vitamin D might alter because this increased plasma and phosphorus level, they are being more absorbed from the because of the vitamin D, and they are released into the blood plasma, which are ultimately urinated or excreted in the form of urinary calcium or phosphorus. It might also result in hypercalcemia and hyperphosphatemia. Because of the increased absorption from the bone and from the blood plasma, vitamin D releases in the blood plasma thereby and results in hypercalcemia and hyperphosphatemia. There's also increased bone resorption because since this calcium and phosphorus are being absorbed by vitamin D and they are being reduced in the bone, this might result in bone resorption. And these the increase of calcium and phosphorus in the blood plasma level, they might also result in renal calculi, that is formation of stones within the kidney. And this calculi, when they are usually present in the kidney, they might also be transformed into other form. They might further be deposited by further calcium and other minerals in the body, and might result in calcification, which is known as metastatic calcification. This so-called metastatic calcification, because the kidney is normal and the other functions are being normally maintained in the kidney, and so it is called as metastatic calcification. Coming to osteoporosis is also one of the feature, that is increased bone osteoclastic activity, increased bone resorption seen in such cases of hypervitaminosis D. Next coming is vitamin E, which is also known as alpha tocopherol. Physiologically, alpha tocopherol is a biologically active fat-soluble vitamin D, and it is usually present available in the form of exogenous source of diet in the form of grains or otherwise nuts or also oils, and is being absorbed by the small intestine and stored in the muscles and liver. And the major function of vitamin E is it shows its antioxidative oxidative effect, that is, it prevents the oxidative degeneration reaction and further protects the body. It also acts as scavengers, that is, the free radicals which have been released from the metabolic activities of certain hydrogen peroxide or otherwise certain oxygen species in the body or nitrogen oxide. These free radicals are being taken up by this vitamin E, that is the tocopherol, and helps in so that it acts as a scavenger by protecting the body from free radicals, which prevent even the cancer, and thereby it also prevents the prostaglandin synthesis. Prostaglandin, which is a cyclic fatty acid and helps in uterine contractions. This is where this prostaglandin synthesis is being stopped or inhibited by alpha tocopherol. So these are certain functions and physiology of vitamin E. Coming to the lesions in vitamin E deficiency, we see vitamin E can also affect the neurons along with the long axis, that is in the spinal cord, and might cause the degeneration of the spinal cord. When when this vitamin E deficiency affects the peripheral nerve, it might result in myelin degeneration in the axons. In the skeletal muscle, it might cause denervation, whereas in the concern to the ocular lesions, there will be retinal pigmentary degeneration can also be seen, which might result in retinal hemorrhages. In cases of RBC, we see that in premature infants, usually we see the lifespan of the RBC is being reduced because of the reduction or deficiency in alpha tocopherol, that is vitamin E. Usually in vitro conditions, that is in lab conditions, on certain experiments, they have observed that there is sterility in both male and female animals because of the deficiency of vitamin. These are certain lesions which I've seen and which are usually associated with vitamin E deficiency. The next vitamin, fat-soluble vitamin, is vitamin K, which is also known as which exists in two forms, that is vitamin K1 and vitamin K2. Vitamin K1 is known as phylloquinone, whereas vitamin K2 is known as menaquinone. And usually this vitamin is being absorbed in the small intestine, and the major function of vitamin K is that it helps in hepatic microsomal carboxylation reaction, which are necessary for the coagulation factor 2, 7, 9 and 10. Coming to the lesions associated with vitamin K deficiency, we see that the vitamin K deficiency might result in hemorrhagic disease of the newborn, since vitamin K is associated with certain associated with the clotting factors and their maintenance of the carboxylation reaction. So any deficiency in vitamin K might result in altered clotting coagulation cascade reactions, thereby resulting in hemorrhagic disease. Other than that, we also see there is biliary obstruction because of vitamin K deficiency, and it might result in malabsorption syndrome, or otherwise vitamin K deficiency can also lead to it might also result because of certain therapies such as anticoagulant therapy and antibiotic therapy also. It might result in diffuse liver disease, that is liver cirrhosis, or otherwise liver failure can also occur because of the vitamin K deficiency. These are certain lesions associated with vitamin K deficiency. Coming to vitamin C, which is also known as ascorbic acid, and the major source of vitamin C, it is available in the form of L-ascorbic acid and is closely related to glucose, and the major source, it is mostly available in citrus fruits as well as certain vegetables like tomatoes and potatoes, and the minor quantities of vitamin C is available in meat and milk. So this vitamin C, it can be readily absorbed from the small intestine, since small intestine is a major area for the absorption of this vitamin C, and thereby it is, once it is being absorbed, then it is being stored in adrenal cortex. Vitamin C is also involved in certain other functions such as oxidative reduction reactions, where it converts the L-ascorbic acid to dehydro-L-ascorbic acid, thereby releasing protons as well as electrons. Coming to the major functions, it acts as an antioxidant and also acts as a scavenger by causing the absorption of certain free radicals and their removal from the body, which is also been seen as a major function of vitamin E. And other than that, it also helps in maintaining certain hydroxylation reactions, that as well as where proline is being converted to hydroxyproline, which can be seen in the connective tissue. So this is one of the function of maintained by vitamin C. Other than that, vitamin C, as it is an acid, it helps in reduction reactions such as reducing the hydroxylation of dopamine to norepinephrine is one of the reaction which is being controlled and being catalyzed by the ascorbic acid. Other than that, the folic acid levels maintenance also is a function which is being mediated by vitamin C, where it prevents the tetrahydrofolate oxidation in cases of vitamin C. And other than that, it also helps in iron metabolism, where we see that the iron which is being absorbed, stored, and which is being converted from ferrous state to ferric state. All these functions, that is a metabolism of iron, is being maintained by vitamin C. These are certain functions of vitamin C. Coming to the deficiencies of vitamin C, when there's deficiency in vitamin C, it might result in certain lesions. That is first and foremost thing, it is scurvy. It is a lesion which is seen most commonly in two peak ages, that is in the early childhood and very aged childhood. So the lesions which are being associated with the vitamin C is hemorrhagic diathesis, that is, it helps in maintenance of certain blood physiological functions. So any deficiency might result in hemorrhagic diathesis. Other than that, it is also has a role in skeletal lesions, in the delayed wound healing, as well as lesions in teeth and gums, where we see patients are being affected with hypertrophy as well as and it also helps in maintaining the inflammatory levels in cases of vitamin C. And other than that, we also see skin rashes in case of vitamin C deficiency. So these are the certain lesions associated with vitamin C deficiency. So these are the pictures, patient showing scurvy of the tongue and bleeding from the gums, gingiva. These are the pictures which can be seen in vitamin C deficiency. Coming to vitamin B, which is a water-soluble vitamin. Vitamin B complex, it is a group of essential compounds which is biochemically unrelated, but they occur together in foods. And coming to the principal members of vitamin B complex, they are the thiamine, which is a vitamin B1, vitamin B2 is riboflavin, vitamin B3 niacin or nicotinic acid, vitamin B5 also known as pantothenic acid, vitamin B6 also known as pyridoxine, folic acid or otherwise known as folate, and then coming is vitamin B12, which is a cyanocobalamin. Coming to thiamine or vitamin B1, the major source of vitamin B1, it is from the pulses, vegetables and fruits also, as well as from the meat. It is so called vitamin B1 because since thiamine was the first B complex agent which has been observed, so it has been termed as B1, and also serves as a major agent in the vitamin B complex group. Coming to the other sources of vitamin other features of vitamin B1, that is the antithyamine. Antithyamine is a thiamine which acts completely opposite to that of the thiamine, and is usually derived from tea and coffee. And usually this the vitamin B, as other vitamins, it is being absorbed in the bowels, that is in the small intestine, and it is being stored in structures such as liver, kidney, bone, and certain other areas which is widely distributed. And major function of vitamin B is in the metabolism of carbohydrate, where it helps in providing energy in the form of carbohydrate to the brain, and this carbohydrate metabolism helps in is one of the major function of vitamin B1, where it also serves as it has an effect on the brain, that is in neuromuscular functions. And the other function of vitamin B is vitamin B1 is in the peripheral nerve conduction, and majorly vitamin B, it is present in an active form, that is in the form of thiamine hydrochloride when it is being observed. This is being phosphorylated to thiamine pyrophosphate, which is an active agent. Coming to the lesions associated with thiamine deficiency, we see that it could be because of it would be one of the primary cause, or otherwise condition cause, and this condition cause is mostly seen in case of chronic alcoholism, which is a major etiological agent for the development of thiamine B1 deficiency. Coming to the what happens in deficiency is that there is failure of the combustion of carbohydrates. Since carbohydrate metabolism is being mediated by thiamine hydrochloride, there is a failure in this metabolism, and thereby there is accumulation of the pyruvic acid, which is one of the carbohydrate agent. So this accumulation of pyruvic acid might result in a disease known as beriberi, and which is the main reason why vitamin B is being named as it is being termed as vitamin B, because it is being derived from the beriberi disease. So this vitamin B deficiency resulting in beriberi, it has major effect on 3 tissues. Based on its effect on 3 tissues, it is being classified into dry beriberi, which has major role in the neurological system; wet beriberi, which is being has a major role in cardiac system. Next, coming to the cerebral beriberi, which manifests as Wernicke-Korsakoff syndrome. So these are the 3 stages which we see, or the 3 areas which are most commonly seen, and so termed based on its manifestations. So there is a picture showing the patient affected with beriberi, showing neurological, cardiovascular function problems, as well as Wernicke-Korsakoff syndrome. So coming to dry beriberi, also known as peripheral neuritis, since it affects most commonly the neuromuscular system, it is being termed as dry beriberi. And these patients usually manifest with weakness, paresthesia, that is partial loss in the sensation, otherwise sensory loss completely, polyneuritis, myelin degeneration, as well as fragmentation of the axons. So these are the conditions which we've seen in dry beriberi. Coming to wet beriberi, we see that the patients usually most commonly the target organ in wet beriberi is cardiac system. That is, a cardiovascular involvement is seen, which results in generalized edema and serious effusions, as well as chronic passive congestion of the viscera. And the heart, it usually appears flabby, that is, it appears as enlarged and globular in appearance because of the dilatation. And the other major role is cerebral beriberi, where we see it manifests as Wernicke-Korsakoff syndrome, and this Wernicke-Korsakoff syndrome is usually divided into Wernicke's encephalopathy, which is initial stages in the syndrome, where the patient might show degeneration, focal demyelination is seen, as well as degeneration of certain ganglion cells, which results in encephalopathy. And this encephalopathy is being followed by Korsakoff psychosis. That is features which have been seen because of the brain hemorrhage in Wernicke's encephalopathy. They manifest as psychosis features. This psychosis features and persists and results in Korsakoff psychosis. The major role why beriberi is seen in cardiovascular system and the neurological system is just because since vitamin B1, that is thiamine, is involved in carbohydrate metabolism, where this carbohydrate metabolism usually produces ATP, which is required or available in the form of energy in the CV system, that is in the cardiovascular system. So any deficiency or any failure or alterations in this carbohydrate metabolism might show its effect in cardiovascular system because of the lack of ATP. Whereas in brain, we see that energy in the carbohydrates metabolism are produced in the form of energy to the brain. So any alteration in this carbohydrate metabolism might result in lack of energy to the brain and might result in dry beriberi or peripheral neuritis. So this has a role in both the cardiovascular system as well as the neurological system. Coming to white vitamin B2, also known as riboflavin, the other terminologies or synonyms for this riboflavin is, it's also known as a yellow respiratory enzyme or cytochrome oxidase enzyme, and also known as cellular respiratory enzyme, since it has a role in respiration where it catalyzes the reaction. So this vitamin B2, or otherwise known as riboflavin, is being rapidly absorbed from the bowel as like other vitamins, and it is being stored in tissue, liver. So the deficiency of any vitamin, any kind of so any deficiency in this riboflavin may result in ariboflavinosis, which could manifest as ocular lesions where we see retinal hemorrhages, or usually since cornea is an area where we do not see any vascularization, but this riboflavin deficiency might result in vascularization of the cornea, which results in retinal hemorrhages, and progressive of this condition results in blindness. The next manifestation is chelosis or angular stomatosis, that is fissures which can be seen radiating from the corner of the mouth, and commonest glossitis, which results in atrophy of the tongue papilla, which results in a bald tongue, or otherwise known as glossitis, and this manifests as the patient might complain with burning sensation or loss of taste in case of glossitis. Next coming is the skin changes, which can be seen where we see changes in the keratin maturation and results in skin changes, and also in these patients there can also be dryness, also could be one of the manifestation. Other than that, riboflavin deficiency can also result in any kind of anemia. So these are certain deficiencies associated with riboflavin, inadequate intake of riboflavin. So this is a picture showing angular stomatitis as well as bald tongue, that is glossitis in the second picture, and angular stomatitis, radiating fissures, in the first picture. Coming to vitamin B3, which is also known as niacin or nicotinic acid, it is a biologically active derivative which is available as nicotinamide, and which is essential for the oxidative, it is a kind of oxidative coenzyme, that is dehydrogenases. So it mediates the reaction which is also mediated by dehydrogenases. So it is available in two forms. In the first form, it is known as nicotinamide adenine dinucleotide. It has a role in dehydrogenation in fat metabolism, carbohydrate metabolism, as well as protein metabolism. Whereas nicotinamide adenine dinucleotide phosphate, which is an other form of nicotinic acid, it helps in dehydrogenation in hexose monophosphate shunt of glucose metabolism. So this is the function of nicotinic acid. So any deficiency in niacin, it results in pellagra, and it is one of the major source of maize. So dietary deficiency on maize can also be seen, where it is since nicotinic acid it was involved in the synthesis of tryptophan. We see that endogenously it is being synthesized from tryptophan, and it shows effect. Any deficiency might result in carcinoid syndrome, or otherwise known as Hartnup syndrome. And next is niacin toxicity, which results in flushing of skin and liver derangement. Any deficiency in niacin is known as pellagra, and this pellagra is an Italian derivated word, where in Italian language pellagra means dry skin or rough skin. So because of its appearance, it has been termed as pellagra. And usually, since niacin is being most commonly attained from the source of maize, and this niacin in maize is usually present in bound form. That is, this bound form is not easily not absorbable, as other vitamins are being absorbed by the liver, by the small intestine. This niacin is not in a dissociated form, so niacin cannot be absorbed. So patients or individuals who are usually subsist on this maize mostly, they might show this niacin deficiency. And niacin it is also synthesized from tryptophan, which is also an enzyme. And this tryptophan usually it helps in production of niacin when it is endogenously synthesized. That is, niacin is endogenously synthesized from tryptophan. So any deficiency in tryptophan can also result in deficiency in niacin. So deficiency in tryptophan is usually seen in conditions such as Hartnup syndrome and carcinoid syndrome. So in these syndromes, ultimately there is also niacin deficiency because of these occur due to tryptophan deficiency, and endogenously niacin is produced only from tryptophan. So these are certain clinical features where we see. Other than that, we also see niacin toxicity. That is when the niacin, it is usually one of niacin is being administered in form of parenteral therapy or oral therapy, oral administration in case of hyperlipidemia. So usually we see that in patients with hyperlipidemia, niacin is being administered where where the levels of niacin reach into an extreme levels, which results in niacin toxicity. And then these patients with niacin toxicity, usually they manifest with flushing of the skin and liver derangement. So these are certain clinical features of niacin. Coming in detail to pellagra. Pellagra, it is as already explained, it is being derived from the Italian language, where pellagra means rough or dry skin, and it usually manifests with 3 disorders, that is dermatitis, diarrhea and dementia, which are the 3 initiated with the letter D. So it is characterized by 3 Ds. Dermatitis, usually we see patients suffering from pellagra, they show skin lesions which manifest in the form of erythema, that is in the form of reddened areas. And this reddened areas or erythema, usually we see in areas where the patient or the individual is being exposed to sun. So most commonly in sun exposed skin areas, dermatitis in the form of erythema is being seen in these patients. Other than that, patients also manifest with the condition known as diarrhea. So similar lesions which have been seen in the skin, such as erythematous lesions, they are also seen in alimentary canal, mouth, as well as in certain other areas, that is in personal parts also can be seen. Next common is dementia, usually because of the demyelination or otherwise degeneration of certain neurons and ganglial cells. Patient might result in dementia, so which is also a neurological symptom which is being seen in pellagra. So these are the certain conditions where the patient is associated with. Coming to the next vitamin, it is vitamin B6, also known as pyridoxine. It is usually available in 3 forms. First one is pyridoxine, pyridoxal and pyridoxamine. So these are an inactivated form or bound form which are being functionally active when they are being converted to pyridoxal 5-phosphate. So the major functions of pyridoxine is majorly in fat metabolism, protein metabolism, amino acid metabolism, steroid metabolism, and it acts as a neurotransmitter synthesis as well as in the synthesis of hemoglobin, heme part of hemoglobin. And any deficiency in pyridoxine, that is vitamin B6, results in convulsions and dermatitis, seborrhea, and chelosis and angular stomatitis or glassitis, also known as ball tongue, and it might also result in neuron degeneration manifesting as neuropathic conditions, and these neuropathic conditions further might lead to depression and confusion. And the other conditions related to the blood disorders is sideroblastic anemia, which we see. The pictures, they show the proper ball tongue, that is it also appears as a migratory glossitis. Coming to the next vitamin is folic acid, also known as folate or vitamin B9, vitamin BC or vitamin N, or otherwise known as folacin. It is a yellow compound which exists in conjugated form, which is being reduced to dihydro and tetrahydrolate forms, hydrofolate forms. The major source for this folic acid is from the fresh green leafy vegetables, fruits, meat, cereals, as well as milk. It is mainly absorbed in the duodenum as well as in the upper jejunum, and as the other vitamins, it is being stored in liver as well as in red cells. And major function of folic acid is that it acts as a coenzyme where it transfers the units linked to the vitamin B12 metabolism, that is the cyanocobalamin. Coming to vitamin B12, which is also known as cobalamin, it is usually present in 2 metabolic active forms. It is a methylcobalamin and adenosyl cobalamin. They are usually the coenzymes which mediate certain reactions where they act as a catalyzers. So this cyanocobalamin is also used as a therapeutic agent in vitamin B12 preparation. And the major source for this vitamin B12 is from the kidney, liver, heart, certain meats. They could be fish, otherwise also it can also be derived from egg, cheese and milk. So these are the sources of vitamin B12, and it is usually synthesized it is usually metabolized in the large bowels by certain microorganisms, and this is being absorbed in the distal ileum and further stored as in liver. Coming to the major functions of vitamin B12, usually we see in the general cell metabolism, that is it maintains the hematopoietic system, that is in the blood cells, they could be the red blood cells or the leukocytes, and also helps in maintaining the integrity of the nervous system. So it has a major function in the body. Coming to the other new additions to the vitamins, it is a biotin, which is also a water soluble vitamin, and it is a member of the B complex group, and majorly available source for this vitamin biotin is meat, soya beans and egg yolk. And the major function of it is in the at the micro level. It shows its functions in gene expression, gluconeogenesis, fatty acid synthesis, and also helps in catabolism of the amino acids such as leucine, and helps in the carrying as a carrier transport system for carbon dioxide in carboxy by accompanying the carboxylase enzyme. So these are certain functions of biotin. So in biotin deficiency, usually we see since it acts as a micro level, that is at the basic level, genetic level, so usually it is an inborn error of metabolism, and in those devoid of vitamin, that is who do not take the sufficient soya sources which are available in biotin. So coming to the lesions which are being associated, since it is also considered as it is one of the major metabolism in gluconeogenesis as well as in genetic metabolism, we see that there is mental as well as neurological symptoms. Other than that, the patient might also complain of anorexia, nausea, and patient might show presence of scaly and seborrheic dermatitis, that is skin lesions can be seen. When it is being observed in infants, when it is being identified in infants, these patients usually manifest with hypotonia, that is decrease in the motility, alopecia, loss of hair loss, and rash usually accompanied in the ears. So these are certain lesions associated with biotin deficiency. Coming to choline, which is also a new addition to the group of water soluble vitamins, it is usually a precursor, which is a precursor form of acetylcholine and betaine. So these are the two forms which are the usually available in inactive or otherwise precursor form, which are being converted into choline by further metabolic biochemical reactions. So this choline is widely distributed in the form of lecithin in foods, as well as it is synthesized endogenously within the liver. So any deficiency in choline might result in fatty liver with deranged liver enzymes. Since it is synthesized in liver, it might result in fatty liver. The other deficiency is because of the skeletal muscle damage with elevated CPK levels is also one of the reason for choline deficiency. Next, coming functions, it is helps in maintenance of the structural integrity of the cell membranes, in transmembrane signaling pathways, as well as in cholinergic neurotransmission, and it also helps in lipid metabolism as well as cholesterol metabolism. Coming to another group of water soluble vitamins, that is the flavonoids, which are usually a form of polyphenols which are present in available sources, fruits and vegetables, and most commonly in berries, grapes, apples, and broccoli and onions and legumes. These are the major sources for flavonoids. And usually flavonoids, as the term itself suggests, it's a kind of chromogen that it imparts color as well as acts as a flavoring agent and an agent which even provides taste to the individual. The major function of flavonoids is it acts as an antioxidant, preventing the oxidative dehydration reactions as well as in cell signaling pathways. So this is a major function of flavonoids. Thank you.